Sorry. It's nice to be back so soon. And thank you, Greg, for setting the stage and making my talk a little bit shorter. So we're going to talk about managing progression in all these patients that Greg just talked to you about who were treated with first and sometimes second generation TKIs in the first place. Same as yesterday, I still have no relevant disclosures, but my institution receives pharma funding for research. Obligatory pathway slide, and in this obligatory pathway slide, we are focusing on the EGF receptor. We are looking at where our existing drugs work against the deletion 19 mutations in the L858R. I hope I'm pointing at the right things because I can't see that far. And we are looking at the dominant mechanism of resistance, which is the development of T790M, and some of the drugs that Greg has alluded to already to try and overcome that. This is the tip of this iceberg, which is why I showed this slide, because there's a lot of crosstalk between these pathways, and while we'll focus on this as the most common mechanism of resistance, it is far from the only mechanism of resistance. So, for the most part, secondary mutations are responsible for resistance. T790M is the most common by a small majority. There are also changes in other genes, amplification of MET and HER2, and we have drugs that we can use for these, although not approved for non-small cell lung cancer. Other mutations exist as well. I'm sorry that I have HER2. Oh, no, I have HER2 in there twice because we actually do have mutations. And the HER2 mutations respond to a variety of things. It's difficult to tell up front what they'll respond to. The early data for transformation of small cells suggested that this might happen a lot of the time, up to 14%. That has crept down as time has gone on, and we've looked at this more. And again, intratumoral heterogeneity, which we talked about a little bit yesterday. I'm going to hearken back to that in a minute. So these are data that Leisha Sequist published years ago now, looking at the observed resistance mechanisms, just to graphically illustrate to you what I said earlier. And this T790M slice of the pie is now about 55 to 60%, depending on where you look. Harkening back to the intratumoral heterogeneity, and I'm going back to a little bit of what I said yesterday, and perhaps to amplify on what Greg said about getting biopsies when you don't have tissue. This is a very interesting paper which was presented at World Lung a couple of months ago, looking at single-cell analysis of mutation status. And so these guys had done some previous work in the lab that said that they could extract single-cell DNA from and do PCR amplification and actually detect mutations. So they actually went into biopsies and they microdissected single cells and went and analyzed them to look for tumor heterogeneity. This actually worked. It's expensive and takes a while, and so I think that this is one of those examples that liquid biopsies may be very helpful. So second generation, Corey asked me, second generation, does that work in resistance? So Greg already talked about LUX3 and LUX-Lung3 and LUX-Lung6. LUX-Lung1 and LUX-Lung4 looked in the second line, and we'll look at the data there in a second. So LUX-Lung1 looked at afatinib versus placebo for patients who had already failed a first-line TKI, one or both, and at least one line of chemotherapy. So this was a phase 2b/3 randomized trial of a large number of patients for this setting, so 585 patients with progressive disease. They had to have been at least 12 weeks on an EGFR TKI, so these are not patients that were primarily resistant probably, and they had had at least one prior line of chemotherapy and up to two. There was a 2-to-1 randomization because it was hoped that this would be something that would help. The primary endpoint was overall survival, and unfortunately there was no improvement with a median overall survival of nearly 11 months for afatinib and 12 months for the placebo. The Japanese groups also looked at this. LUX-Lung4 was a predominantly Japanese study, slightly higher dose of afatinib. 62 patients, they were not pre-screened for EGFR mutations, but most of them had them. And 82% of those patients already had acquired resistance to either erlotinib or gefitinib for the most part. Overall response rate of only 8%. So taking these two things together, afatinib isn't recommended as single agent therapy for EGFR mutant non-small cell that's refractory to first line. Can you do something to make that better? Well, this interesting idea of attacking the EGFR mutant by both internal with the IB and external with the MAB together in TKI resistance with and without T790M. This was a phase 1/2 study, usual dose of afatinib, usual dose of cetuximab, 126 patients, EGFR mutant, progressing on either erlotinib or gefitinib in the phase 2 portion, with a median duration of prior TKI of about a year. So these are not, again, patients that are primarily resistant. 79% of them had also had chemotherapy, slightly more than half, at least 2 lines, and the T790M was found in 57% of the 124 patients in whom it could be tested, mostly deletion 19 and then some L858R. The overall response rate was 29%, so compare that to the Japanese trial with an overall response rate to the single agent afatinib of about 8%. We're obviously comparing 2 different patient populations. And nearly 20% of patients had at least 50% tumor shrinkage. The response rates were seen in both T790M positive and T790M negative patients. Median duration of response nearly 6 months, median progression-free survival about 4.5 months, and grade 3 and 4 treatment-related AEs in 44 and 2%, so only 2% grade 4, and what you would expect, rash and diarrhea. There were 2 respiratorily related, treatment-related deaths, but treatment was discontinued for toxicity in only about 13%, and 64% of the patients that went on study didn't require a dose reduction. So these are the 3rd-generation TKIs. The 2 that we're going to focus on are ruxolitinib and AZD9291, which is now called osimertinib, and Greg and I pronounce that slightly differently, and I have no idea how the company pronounces it. There are multiple other agents in early clinical development. So this AZD9291, which has already been introduced to you, is an irreversible mutant-selected EGFR TKI. It spares wild type. Its potent inhibition is for both the deletion 19 and L858R mutations, as well as the primary resistance mutation T790M, and it has worked well in xenografts. The clinical activity was studied in a phase 1 dose escalation study with an expansion cohort that's already been introduced to you in the form of a picture of the front page of the journal article. This has been presented and published in several forms, and Pasiani is usually the lead investigator. So in the phase 1 portion, 31 patients with EGF receptor mutations and acquired resistance to TKI. Dose escalation can be seen here, and then about a 200-patient dose expansion cohort with the overall response rate among all of the patients of a little bit more than half. So this is a very good response rate in second-line therapy. In the T790M positives, the response rate 64%. In the T790M negatives, there are still some responses. So there's something else going on here with this molecule or with these patients. The obligatory waterfall plot is seen here. This is for the overall patient population, so you can see the response rates are good and significant. In the T790M positive population, there are very few of those patients that didn't respond, at least some measurably, although not all by RECIST criteria. And in the T790M negative population, the portion of the curve of patients that didn't respond is higher, but there are still responses, although the RECIST responses are less. So what does this translate to in terms of progression-free survival? Here with the confidence intervals are the survival curves for T790M positive and negative patients, so we do get responses in both of these groups. So adverse events, what you would expect: rash, nausea, diarrhea, some itching. There weren't any DLTs. There was very little hyperglycemia, which we'll get back to when we get to ruxolitinib. The grade 3 or 4 toxicities occurred in about a quarter, but very few patients had dose reductions and very few patients discontinued, and the 80 milligram daily dose was selected for ongoing phase 2 and 3 trials. This is the list of those trials. So we have phase 2 single-arm trial in the second line. I think this is actually completed accrual in T790M positive patients. Or a 3 is comparing the experimental agent in this setting with platinum pemetrexed in second-line T790M positives. So I'm not sure whether this will change now that the drug has been approved. The so-called FLORA is a phase 3 international trial in the front line versus erlotinib or gefitinib. And the so-called TATAN trial combines osimertinib with other agents to try and address resistance. So we've got MEK inhibitors, MET inhibitors, and immunotherapy. This was approved as of about 10 days ago and is now called osimertinib. And you'll notice that I put that in there so that people know what it is. I'm not saying it, Corey. Okay, we are now going to move on to ruxolitinib, and this is a little bit of repetition for those of you who were here yesterday, although in a different context, so remember that repetition is learning. So EGFR TKI therapies obviously have limitations, and the emergence of the T790M, as we've been talking about, is one of them. Ruxolitinib was designed similarly to why AZD9291 was designed as an oral irreversible inhibitor of both the activating mutations and T790M. It's been designated, had breakthrough designation since May of 2014, and was initially studied in single arms with acquired resistance, and TIGER-X is what we talked about yesterday when we were looking at liquid biopsies, and it's what we will talk about again today. And as in yesterday, Alicia Sequist kindly lent me her slides. So this was a phase 1/2 dose escalation and expansion study of what was at that point Clovis 1686 and is now ruxolitinib. The patients were eligible if they had advanced or recurrent non-small cell with documented EGFR mutation. In the phase 2 portion, they had to have a biopsy and documented T790M status as well. Disease progression had to be while on treatment with the EGFR TKI in the phase 2 portion, and treated and stable CNS metastases were allowed, and I'll get back to those in a minute. There were several groups for analysis, so everybody got analyzed for safety. Efficacy was analyzed in patients that had centrally confirmed T790M and plasma T790M, and then the patients with paired plasma and tissue are the group that we talked about yesterday for liquid biopsy, looking at comparative efficacy in those two groups. A lot of patients had a history of CNS disease, so this is 41% of the total population, and I'll just make mention of those in a minute. Here's the best response at all doses in the 243 patients that had tissue-confirmed T790M positive, so this obviously an impressive waterfall plots. In the patients who had plasma T790M, similar waterfall plot, and we talked about that in detail yesterday, so I'm not going to go over those again. Sorry, I'm having trouble with this thing. We also talked yesterday about the fact that whether either plasma or tissue were positive, the response rates are about the same. And looking at the progression-free survival in patients with the centrally confirmed T790M, we see a promising set of progression-free survival curves. And in blue, we see all patients, and in red, we see the patients who did not have CNS metastases. The common treatment-related adverse events were what you would have expected, apart from hyperglycemia, which was seen in a lot of patients. And the hyperglycemia that was at least grade 3 or 4 was seen in 17% overall. There wasn't any interstitial lung disease in the 500 milligram BID dose group, although there was some in the overall study population. I think it was about 1.5%, although I can't see that, so I'm hoping that that's right. The ruxolitinib continuation was felt to be possible as long as patients responded to steroids, and there wasn't any fatal interstitial lung disease. There wasn't any bad paronychia or stomatitis, some of the bugaboos that really torment us with the first and second generation EGFR TKIs. There was some QT prolongation in the 500 BID dose. It was low, around 2.5%, I think is what that says. And the treatment-related AEs that led to drug discontinuation were low, only about 2.5% at the 500 milligram dose and 4% in the overall study population. The hyperglycemia was not expected, and so once it was recognized, it was managed with some algorithms, which I'll talk about in a second, and there wasn't felt to be any contraindication in patients with pre-existing diabetes. So this is iatrogenic insulin resistance that comes from one of the ruxolitinib metabolites. Since it wasn't seen in preclinical testing, it was really unexpected, but a monitoring and treatment algorithm was devised with treatment with both oral insulin sensitizing agents or SGLT2 inhibitors. We try not to use insulin as the first-line therapy, and that reduced the extent of grade 3 or more hyperglycemia from 22% before this until down to about 8% after these were instituted. We haven't really talked about resistance to the third-line agents now, but with the plasma analysis built into this trial, they've been looking at that, and there are a smattering of different things. But the C797S, which is a mutation which seems to be responsible for resistance to some of the other third-line agents, wasn't seen, at least at the time of this presentation, and according to Alicia, there hasn't been any since. So the authors concluded that there was good activity of ruxolitinib and it was well tolerated at the recommended dose with a response rate of 60% and a disease control rate of 90% when centrally confirmed tissue for T790M was seen and at the 500 milligram BID dose. The grade 3 hyperglycemia 17% overall, but didn't require dose modifications or discontinuation. The estimate of overall PFS was immature at the time of this presentation, so stay tuned. The T790M plasma testing, as we talked about yesterday, was feasible. Overall response rates existed in about a third of T790M negative patients, so something else is going on there, and acquired resistance seems to be a little bit different than with some of the other agents. Now, getting back to the CNS disease again, we had 40% of patients on this trial did have existing CNS disease that had been treated. And if you look at the waterfall plot in the T790M positive centrally confirmed populations with and without CNS disease, you see that there are still very good responses in the CNS disease patients. So this is an important thing to consider as we use these agents. Looking at drugs to try and prevent and delay resistance, this was presented by the Clovis folks at World Lung a couple of months ago, and they have been looking at multiple mechanisms of resistance and starting to look at studies with some mutations. C797S has been observed with other agents, but not with ruxolitinib, and they're using some in vivo models to look at resistance and try and figure out what's going on here and what drug combinations should be used. So they concluded that MET amplification was a possibility and tumor heterogeneity, and it was also a possibility. They're trying to do combinations with trametinib, which seems to restore activity in resistant mouse models, and they're trying to look at aura-A kinase inhibitors as well as a smattering of other combinations. So stay tuned for some of these things. A brief comment about another couple of agents. So ASP8287 was also presented at ASCO, I think, last year and has been published. A very small number of patients, but responses in the majority of patients with T790M with nausea and diarrhea as the main adverse events. HM61713 has been studied primarily in Korea and other Asian areas. It, again, is an irreversible T790M inhibitor. Large phase 1 trial of 83 patients with 48 of them with a T790M and an overall response rate of about 29%. So a little bit lower than what was reported in the studies of AZD9291 and of ruxolitinib, but toxicity was mild and well tolerated. And if you look at the toxicities, they're about what you would expect from these agents, with exception of the hyperglycemia seen with the ruxolitinib. So what are we going to do to try and figure out the differences between sensitive and resistant non-small cell? I put this in. This was presented at World Lung, and I actually didn't put the presentation in. I just put in the press release just as a matter of interest. So Greg mentioned that we do next-gen sequencing. There are some ways of sequencing mutations at different stages along the development of the cancers, looking at clonal diversity. And this interesting release from the folks at Singapore and the Genome Institute of Singapore suggested that for these patients that are the primary resistant group, so this is really one of those groups that you want to look at early on to see if we can do something better, that there might be coexisting so-called driver trunk alterations, and that might cause the problem for this 10 to 20% of patients that are resistant a priori. So stay tuned for that. I think that that's going to be something that will be interesting to see, this hypothesis that there are additional subgroups with mutations that will further emerge. We may need to use this information to develop both combination therapies and perhaps different strategies up front for those folks. So, what is the role of second and third generation TKIs in resistance? Afatinib has minimal activity as a single agent in resistant patients, but may be effective when you combine it with cetuximab in some patients, and this may be a good strategy for some of the T790M negative patients. Osimertinib has a response rate greater than 60% in the T790M positives, a disease control rate greater than 90%, and is now FDA approved as osimertinib. Ruxolitinib and osimertinib are fairly similar in T790M modulated resistance, but hyperglycemia management is clearly needed with ruxolitinib, and mechanisms of resistance to these two agents may differ, so this is an area that is certainly ripe for further research. And further drug development or combination therapies are clearly needed for the patients that are non-T790M and to manage emerging resistance. And with that, I will give you, I gave you less seconds. I gave you 41 seconds yesterday. I'm only giving you 21 today.